Good afternoon, everyone. I am Robert Hall. I'm your chairman of Project Elect, Enthusiastic Leaders Engaging in Changing Times. And as promised, we're going to continue to bring information to the community. We're looking to be that conduit to our community, to the grassroots of getting information out there that we believe that's important to our everyday lives. So today we're going to continue some on COVID conversations. We know that is still going on. There's a lot of things going on here in Mississippi and national with COVID. And our guest today is none other than Dr. Vernon Rayford, who is the community doctor. And I do have a lot of new questions for you today. If you just say hi to the audience.
Hello.
Yeah, thank you. So, and Dr. Rayford has brought on a wonderful person that we are looking to just really get to know. And right now, I know that you're Dr. Renee Walters.
Yes.
You are a hospitalist.
Yes.
Okay. Welcome to Project Elect.
Thank
We're looking
you.
forward to getting just kind of into the conversation of learning who you are, what your specialty is, and what do you bring to our community. So we always want to start with maybe an update. Mm-hmm. And I know you said that, there's not a lot of changes in how we're dealing with COVID, but I was reading this morning, mm-hmm. and I really got concerned with the state of Mississippi. Now I know that there's nationally over 600,000 dead. Mm-hmm. And even though we have the vaccines out there and things are going on, mm-hmm. I was kind of concentrating on Mississippi. And I noticed that only 33% of Mississippians mm-hmm. have been inoculated. Mm-hmm. That was concerning because I thought we were really rolling.
Yeah.
So can you explain what's happening with that and with the country opening back up and with our city and state opening back up? How does that affect us?
So from a number standpoint, the COVID numbers are lower. Number of cases, hospitalizations, ICUs, those numbers are lower. Fortunately, the number of deaths are lower, but they're still happening. And we've crossed the 600,000 milestone at a slower pace than we were, but those numbers are still occurring. Add to that, there are places in the country who are doing a great job with getting the vaccines out. There are many states that have a significant portion of their adult population vaccinated, working on vaccinating their adolescents. In Mississippi, we are the worst state in terms of vaccination rates. So if you look at a percentage of our total population, 33% have had at least one dose, 30% have had 2 doses. If you look at the adult population, 45% of adults have had at least 1 dose. President Biden's goal was to have at least 70% of adults in America having at least 1 dose by July 4th. We are not on pace to meet that target. So, how do you put that in real term numbers? If you see 2 adults in Mississippi, 1 of those adults are not vaccinated. Added to that, we have opened. We've relaxed masking mandates. We've removed the capacity limitations. And so if you walk around, you experience a kind of what could feel like a post-COVID environment. Unfortunately, there's a harsh reality, particularly in states like Mississippi, is that for those who are unvaccinated, they're really kind of opening up at their own risk. And so, another real term number, if you go into Walmart, you see 100 people, 67 of those 100 people have not been vaccinated, and not 1 mask. And so we have reason to, be kind of optimistic that we have vaccines that are safe and effective. But we also have reasons to be cautious that we, are positioning ourselves by being open to be, at risk for, another surge. It just hasn't happened yet. And so, because going back to your core answers is that there's not enough vaccines happening in Mississippi. And now there is something positive about the small number of vaccinations is that when you look at the total vaccines that's been given out, 36% of those vaccines have been given to African Americans, and that's pretty close to the representation in the population. And so some have celebrated that number as far as achieving vaccine parity, but we have parity with a very small number.
Wow. And I've got some more questions for you. And Dr. Walters, I want to bring you into this. But first, since you are kind of the newcomer, our special guest, just tell us a little bit about who you are and what do you do and how long have you been here?
Well, I am an East Coaster. I'm grew up in New York City and have been in Tupelo. My husband and I have been here for the past 5 years. Next month will make 5 years.
Welcome.
Thank you. Thank you. I'm a Tupelopian, I think.
Okay.
And I am an internal medicine doctor. That's my specialty. Specifically, I work as a hospitalist, as you were talking about that term.
You're going to have to explain that.
So a hospitalist is a physician that treats patients specifically in the hospital setting only. So I do so as an internal medicine doctor, and other specialists can do that as well.
Wow. So, and I've always been told, do not ask ladies their age. But you look like you're very successful. I mean, awesome career. I mean, your family's here. And we're wanting to encourage our younger people out there, so our younger females. How old are you?
You said not to ask.
Not to ask.
She doesn't have to answer.
She don't have to answer that. But anyway,
I tell people when I get asked that all the time in the hospital by my patients. I just say old enough to be a doctor.
Old enough to be a doctor. So when it comes to the COVID
Yes.
and all of the things that's going on, where do you feel in as a hospitalist in taking care of our patients?
So in terms of COVID, so in the beginning of the pandemic, we had a few dedicated hospitalists that were seeing strictly COVID patients, allowing for the rest of the group to see all the other patients in the hospital. But as the pandemic worsened and the need increased, basically all the hospitalists, and the group is probably about greater than 30 hospitalists in the group, and we were all seeing COVID patients. So I started seeing COVID patients at the end of last year into the beginning of this year. I currently don't see any COVID patients. And so we took care of them from the slightly milder symptoms to the most severe patients.
And I know that things have changed, and you say you're doing some different things with patients now. What is the general, I guess, the area when you bring COVID patients in? Where does it actually start? How do they know that they're sick enough to come to the hospital, and when should they come to the hospital, even with being vaccinated now?
Okay. So according to the Centers of Disease Control and Prevention, they say if you've been exposed to someone who's had COVID, you need to quarantine for 14 days. So you'll be looking out for the typical symptoms of the shortness of breath, fever. But once you notice worsening symptoms, there's certain indicators that you say you have to seek emergency medical care, such as chest pressure, persistent chest pressure, chest pain, trouble breathing, new onset confusion, as well as changing in skin color. I know with African Americans there's going to be different tones, but we usually say if someone looks more paler or grayer looking, their lips start turning blue, their nail beds start turning blue. Those are emergency indications that you need to seek medical assistance.
And even with the vaccinations out, and like Dr. Rayford said, we're about 33%, and I think a large percent of that is the African Americans in Mississippi. Am I correct on that?
Well, no. I mean, we just the dose is 36% of it is in African Americans, and so that's about where you would expect from a population standpoint. Mm-hmm. So there's still majority of African Americans are unvaccinated too. So there is a reason for every group to improve their vaccination rates, because we can't one group can't overcome COVID without the other. So we're going to have to get it all together. We either have to get infected or get vaccinated for COVID to kind of go back down to non-pandemic levels.
So really, we're not out of the woods, is what you guys as medical professions are telling us, and we're kind of feeling free post-pandemic. Mm-hmm. So what would you tell our audience now? I know that we feel very comfortable being vaccinated. And so one of my questions was, after vaccination, how long is that going to last? And I'm one that I had the Johnson & Johnson. So how should I feel now, being 2 months in, or 3 months, I think, is when we got vaccinated. So how comfortable should I feel?
I don't believe you should feel entirely comfortable, because we know that getting a vaccine does not prevent you 100% from not contracting COVID. So we should still be wearing masks. We still should be social distancing as much as we can. But the studies are showing, the vaccine is very efficacious, meaning it's a pretty effective vaccine. Even with these new variants that are coming out, one should feel more reassured that they did get the vaccine to prevent them from the illness. And what I would tell people who have vaccine is look at the data. It's showing that the states that have higher levels of vaccines are showing lower hospitalizations, and vice versa. So the more vaccinations we have, the more the increased chance of us getting back to normalcy sooner than later.
So, Dr. Rayford, what's the consequences right now that we're opening back up, we're loosening up, we're not wanting to do, like Dr. Walson said, continue to wear the mask, continue to social distance. What are the consequences of that if we don't continue to push the vaccinations?
I think, and this pandemic time has been pretty a different experience. It wasn't long ago that we were in the winter surge, the worst we've ever seen the pandemic in the state, in the country. And that was just, 5-6 short months ago. The risk is, the biggest risk is we will see numbers like that again. The biggest tragedy is that for a large part of that, those would be almost entirely preventable. And so now it's compounded. In December, January, we did not have the widespread availability of 3 safe and effective vaccines. And so that part of that surge, there was, we were doing the best we can with what we had. The next surge is going to be more tragic, because we will see, families that are forever changed. We will see people who get COVID who won't be the same. And so, many of the consequences, unfortunately, we've seen them before. We all know, I think if you look in the community, there's no community group that's been untouched. There's just so much grief around. Each group I've talked with, it's always been, we know of someone who you didn't expect to die from COVID, someone that had COVID and still not the same, particularly with some of the symptoms that you may laugh off, but there are people who are utterly miserable because their taste and smell is awful. And many people develop some problems. I talked to someone last week where lost taste and smell, it came back, and then a few weeks later they developed this abnormal sense of smell. So things really smell putrid. And it's just a miserable experience that they can't eat certain foods. And so we know very well the consequences. We know very well the consequences. It's just... the tragedy is that it's almost entirely preventable.
Wow. Now, this is kind of disturbing to me, and I'm just saying it from being, in the community, hopefully, pretty healthy African-American male. But what you're telling me is that there's a new variant out there, and we're wanting to loosen our grip. What is this new variant that we're so afraid of now? Because we're thinking we're out of the woods. And you're just spoiling that for us. So what is this new variant, and why is it different than the variants that we already have, or this vaccination should be conquering, if that makes sense?
It makes sense. It makes complete sense. We have seen several variants of the virus. Just like any virus or bacteria, for instance, the longer they're around, the increased chance of them to change. And that's just basically what the variant is, just a different form of what we saw initially. And the most recent variant, I don't remember the exact name, I know it starts with a B. They have their nomenclature. And That one I believe is the Indian variant. I don't want to categorize things by country, but generally speaking, that's what they're calling it. And so far, what the studies are showing is that it has these, I believe the Johnson & Johnson, the Pfizer vaccine, if not mistaken, all the vaccines have shown effectiveness against that variant. So another reason why people should get vaccinated, because as these variants come out, they become more virulent, meaning that they can kill one easier, or rather you can contract it easier than the previous. So it can be deadlier. Yeah. That's the concern.
And it can be confusing. I'll jump in on the variants because we've called them different names in this short period of time. So, we started with the country of origin or the country of description, and then the official nomenclature with the B's. Now they've adopted the Greek alphabet system. Okay. And so the Alpha variant was the one described in the United Kingdom. Is more transmissible. The Beta variant was the one described in South Africa that looks like it can evade some of the immune system recognition. The Gamma variant was the one described in Japan, but they have Brazil as kind of in Brazilian travelers. And then the Delta variant is the one that they're calling the one they identified in India. And you've probably seen the news, they call it the double mutant or things like that. And what they're talking about is there's the changes that they've had can make it spread easier, and can also evade some of the immune response. The vaccines do show that they work against them. The vaccines may not prevent as much disease, which we do need to be conscious of. Of the variants and their presence. And the Delta variant, which is one they described in India, is now being predicted to now become the dominant strain. So 3 or 4 months ago, it was the Alpha variant. So the UK variant was the one that became the dominant strain. Now we're moving on to the Delta variant. And the simple reality is, as long as large groups of people kind of serve as a testing ground for COVID to get stronger, faster, better, we will still have to contend with what COVID is throwing at us. And so there is a good need for us to get and vaccinate the population so that you won't have tens of thousands of people in the state of Mississippi serving as the breeding ground for the Mississippi variant. And so what we really need to do is look around the world, and if COVID is surging and is causing things, we should say it's not here yet. We need to be on the lookout, and we also need to be cautious about our opening up. I want to do more of the things, but we need to be cautious about it. And also we need to be willing to take a step back, based on the numbers. Let's really be guided by the numbers.
So with things constantly changing, and when we was coming in earlier, we talked about a new training program with the residents that you're a part of as a hospitalist. And so a two-part question. Obviously, we're still in COVID, and we're going to continue to be in COVID. It's not going to go away anytime soon. We just continue to fight. How would someone that has a patient in the hospital work with a hospitalist? How should the family react with a hospitalist?
How should they react? So I'm not sure.
How would they work with you? What do you, and I could just imagine, I've had friends with loved ones in the hospital, and they had to do the video chat, they had to do all of these things. But I'm wondering, what advice would you give the families in keeping, understanding what that patient has to go through in the hospital without them being able to sit in the room?
So that would be specifically for patients with COVID.
Right.
Okay.
Yes.
So the majority of, basically I would say most patients in the hospital will be seen by a hospitalist. So they're the internal medicine doctor who's going to diagnose the issue they have, treat the issue that they have. There'll be other specialists involved in their care as well. So unfortunately, when it comes to COVID, that has changed many of our practices where the patient is alone in terms of not having any family members around. And that's very different for me in my practice, where at least I would have a family member in the room, and now I usually have never met any of those family members. I've only spoke to them over the phone, and I'm having difficult conversations over the phone with someone who's never seen me and I've never seen them. So that part's tough. So that's where great bedside manner comes in, compassionate care comes in, and we should be with all your patients. When it comes to these COVID patients, you have to think about things in ways you haven't before. So in my practice, I try to keep the patients' families abreast of everything that's going on because they want to know everything that's changed. Will my family member be one of those that don't make it? And what can we do and what are you doing to help them? So keeping everyone informed is what I try to do my best at.
Well, listen at you doctors, and we're stressed as family members, as a community, but you're taking care of the patients, and then you're also concerned about the family members, and so that's compassion. I can see the compassion as you were talking. You know, you're worried about the patient, but you're also worried about the family members and what they're feeling because they're not there. So we thank you guys for that. So the new program, the training program that I think the medical profession is constantly pushing and training, and I don't know if it's dealing directly with COVID or maybe sickness in the community as a whole. Could you kind of enlighten us on what's coming with that?
So this is pretty exciting.
Okay.
We're starting a brand new internal medicine residency program. So training medical doctors, they're medical doctors. They graduate from medical school and they have chosen to specialize in internal medicine, which is my specialty. And we're starting with a class of 12 that will be starting. They'll start their orientation at the end of this month, and their first day seeing patients will be July 1st. Wow. So they will be seeing all patients in the hospital. COVID patient is no different from any other patient. They still have chronic issues that you have to deal with, and COVID is another infection. You know, internal medicine, we deal with complex medical problem and disease processes, and they have to be a part of it because these are the kind of patients they'll be treating once they're done with our program. So our program is 3 years long. That's a typical internal medicine residency program length. And the goal is to have 25 residents in each class by 2025. So our first class of 12 will be starting very soon.
That is awesome. Do you play a part in the training program, or is that part of your duties every day to work with the new resident?
No, so I will be one of the core faculty members. So we have about 4 core faculty members, and every month, see, I'm a hospital, so I see all the hospitalized patients in the hospital. We will have a group of internal medicine residents under our care who will be helping us take care of the patients throughout their 3 years. So we'll be teaching them about internal medicine, teach them how to do physical exams, using the science that they learned in medical school in addition to evidence-based medicine to help diagnose those patients.
Wow, that sounds exciting. And it sounds exciting because we have all of this right here in Tupelo.
What's even more exciting, I'm also excited because they're not going to be only in the hospital. Mm-hmm. So part of an internal medicine training program is actually going to involve taking care of patients in the clinic too. And so the clinic where I practice at IMA, the north side of the building is devoted toward the training program for those residents. And so they will be able to see people in the clinic, whether they've been in the hospital, they see people in the clinic after they've been in the hospital. There's going to be 12 new physicians coming to the area. So if you're looking for a internal medicine physician, that you got 12 to pick from, and part of that training, so there's the in the hospital training, there's the out of the hospital training that's going to happen where they're going to learn, and it's a common pathway. So Dr. Walters and I are trained in internal medicine where we've had the hospital component as well as the clinic component. And so it's really exciting to have 12 brand new physicians who are going to be working in the clinic as well. So for those many scores of people who are hospitalized and don't have someone to follow, they'll be able to start a relationship or continue the relationship that started in the hospital by following that resident to the clinic. And, many patients, when they look back, say, yeah, I started seeing them in the hospital, and then they followed me outside the hospital. And that's another really, really exciting part, that it brings us all together, the in the hospital doctors, the out of the hospital doctors for the internal medicine residency.
That is pretty cool. Now, when does this start?
So the orientation begins at the end of this month, and July 1st, first day seeing patients.
Wow.
So July 1st.
I can tell you're really not happy about this.
No. July 1st, man, that is the rite of passage day around the country.
Yes,
that
it
is
is.
when the newly minted, physicians who just finished their medical school, and some who've taken a little longer, that's when they start the apprenticeship, but kind of, and maybe a little unfamiliar about what the training process is. And so as a physician, we all have to go to medical school. And that's typically 4 years. And then we all have to, if we're going to practice as a physician, we all have to do an apprenticeship that's called the residency, starting out. And for those who want to maybe specialize into something else, they will do what's called fellowships. And the residencies can be anywhere from as short as a year to as long as, 9, 10, 11 years. Some of my classmates from medical school who chose surgical subspecialties, just 2 or 3 years ago finished their program. And so the internal medicine as a specialty is the pathway to cardiology, gastroenterology, endocrinology. And so, if you're seeing a heart doctor, a lung doctor, a kidney doctor, they all started in internal medicine. And so, it's it will be the first training program for, and the ultimate hope is that, when, of these 12 physicians who are going to join us, a good thing about residency training is that a significant number of those stay in the community. And
That was going to be my next question.
Significant number stay in the community, and so they're being pretty, they have some great bold visions in terms of class of 25 is humongous. It's humongous, and being able to retain 70, 80, 90% of those, you start a class every year, and so that's another boon for our area, that we need physicians in Mississippi.
That is awesome. We're getting ready to close, but Dr. Walters, what would you say to encourage the younger people out there to maybe that's thinking or on the verge of maybe being a nurse or getting in some type of medical field to help? What would you say to encourage them? Because a lot of people think it's hard as I don't know what. So what would you say to encourage someone to take that step and go after it?
I would say anything's hard that's worth doing. Find good mentors. I'm a mentor. I'm willing to help in any way possible. I had great mentorship as well. I sought out mentorship as well. But if you're passionate, the need is there, and you want to take care of people, it's there. The opportunities are there.
Just go for it.
Go for it. Go for it.
And I think that's great to have mentors right here that's just willing to say, if some young kid or a person need to just talk and understand what the career entails or need that push, you guys are willing to be that.
100.
I think that is awesome.
Yeah, and I think, as hopefully you meet more physicians with Project Elect, I think that sentiment is going to be shared by all of us. I think we've all seen the value of mentorship, and know that that's going to be a key, because we're still young, but we don't plan to work forever.
I'm not going there again.
We're still young, but we don't plan to work forever.
Yeah.
And so,
Somebody's going to take care of you guys.
Someone's going to need to
Right.
take care of us, and then someone's going to need to take care of the patients that I'm taking care of now. So someone's going to need to, to kind of take over. And so we know that mentorship is a really, really, important part of that. So take us at our word. If you, Facebook, I'm going to jump the gun and say, share it. share this,
Yes.
tell everybody about Dr. Walters. If, the people who have met her, the families, they always remember her from the hospital, about just kind of, the clinical work and just how kind she was with the, clinical work. If you do good clinical work, sometimes folks don't consider being kind too. And to have it together, it really goes a long way, especially in the hospital, because if someone's sick enough to be in the hospital, it's a life-altering kind of thing. And for many families, this hospitalization may be the final hospitalizations, and so it may be something that they carry with them for the rest of their lives. And I would tell Dr. Walters that the patients of mine that you've taken care of, they love you. They love you. And so and they even ask for you. So I even look to see who's on. It's like maybe she'll get to take care of you again if I don't do good enough to keep them out of the hospital. But they really do love that you've taken excellent care of them, and we're so thankful that you're in the community and that you're staying, and that you're also investing in the community by investing in this training program. That I'm really excited.
I can't tell you're really
and
excited.
a little jealous because I want to teach too. I think I wear a little bit too many hats.
Yeah, you do have quite a few hats. Again, Project Elect, enthusiastic leaders engaged in changing time. We're here talking to our original Dr. Vernon Rayford, Dr. Renee Walters, who is a newcomer to our community that's doing extraordinary things.
So I like to call it extraordinary. I've been in Tupelo all my life, Tupelo, Lee County. We're a small city, 38,000. And it's been with young people that get their careers and so on that they try to find somewhere else to go. You came to Tupelo. Can you tell me why? Can you tell our audience why?
Yes. I get this question asked all the time by all my patients. Why am I here? They hear the accent. They hear it's not a southern accent. I tell them it's opportunity that brought me to Tupelo. Usually during the last portion of your residency, you'll get lots of offers for jobs. And one of the offers were in Tupelo, but I never thought I'd be in the South. I always said, we'll never live in the South. And for whatever reason, we said, let's just check it out. And I was blown away. I could not believe how large this hospital was in such a small town.
And it's the largest rural hospital,
The largest,
I think, in the nation.
yes, it is.
Yeah.
And all the
I knew
specialties all the specialties that we have, patients are transferred into our hospital. A lot of the smaller hospitals, they transferred out. So we get to see so many illnesses and morbidities and different things like that, things I never expected. So this has been a win.
Your meet and greet with Project Elect and maybe the community of those who maybe don't know you, maybe they'll know you now. Any closing words, and it could be anything. It could be about COVID, it could be about your residence training coming in. What did you want to tell our audience at Project Elect? And I hope that's not putting you on the spot.
Let me see, what do I want to tell the audience? Other than get vaccinated, health is wealth. It's, COVID, this pandemic has taught me a lot about the importance of health and family, getting closer together. I can say personally, I feel like I know that my husband and I have gotten closer because of the pandemic. You're forced to be home together. Cherish
every moment.
Every moment.
Right.
Yeah.
That's well said. Well said in short. I will have to say we're getting ready to close. Thank you, Dr. Rayford. Thank you, Dr. Walters. Again, Robert Hall, Project Elect. We're trying to move information into the community, and this is very dear and near to my heart. Anybody that has had, and I know all of us had, someone in the family to contract COVID or pass away from COVID, a neighbor that have lost a loved one, friends, mothers, fathers, sisters, brothers, cousins. This is serious, serious, serious conversation. And what we have here in our community, I think, is second to none. We have doctors that's willing to give their free time after clinic, after they see the patients to give information to our community, and we're wanting to take advantage of that. So again, thank you, Maurice, our cameraman, our secretary of Project Elect. Thank you, our vice chair, Kenneth Miller, not Kenneth Miller, but Kenneth Wheeler, who make it possible for us to sit here at the North Mississippi Medical Center. And until next time, we will see you soon. God bless.